This is a short review of stroke. There are basically two main classifications of stroke: the occlusive or ischemic stroke, and then the hemorrhagic stroke. When we look at occlusive or ischemic strokes, you can note in the normal artery shown below and then the artery next to it to the right, where there has been a plaque buildup causing an occlusion. Or another possibility would be a blood clot has formed at this site or has formed elsewhere and traveled to the site, but whatever, whether the artery is clogged up or a clot has formed or lodged there, those are the ischemic or occlusive strokes, and these are 85% of the strokes that we see. The other 15% are hemorrhagic strokes, where there's a rupture in the vessel and an actual bleed or intracranial hemorrhage. Regardless of the cause, whether it be ischemic or hemorrhagic, the stroke patient appears the same in our assessment. The only way to know what type of stroke is to get a CT scan, a CAT scan, at the hospital. So standard strokes, signs and symptoms include the list here. The major ones that we talk about pre-hospital are facial drooping, slurred speech, and one-sided weakness. And the symptoms can include a headache. They don't have to. They can also include confusion or agitation, and therefore stroke is one of our altered mental status causes. Some patients may be dizzy or have vision problems. So this is a list of most of the signs and symptoms that may occur, but there's no guarantee that any 2 or 3 of these will occur with any individual patient. And then the most important thing for us to remember is that hypoglycemia can mimic stroke symptoms. Patients with low blood sugar can look just like they're having a stroke, so we must be careful not to be fooled by that. So the standard pre-hospital stroke test that we use in our system and that's used in many places is called the Cincinnati Pre-Hospital Stroke Scale, and it includes 3 elements: the presence of slurred speech, the presence of a facial droop, and the presence of one-sided weakness. We test the slurred speech by having the patient speak to us. A lot of physicians, neurosurgeons, and neurologists like to use the phrase, "You can't teach an old dog new tricks," in order to elicit slurred speech from patients. Remember that slurred speech can be caused by many things. Stroke would be one of those. We also look for a facial droop, a one-sided facial muscle paralysis, which will cause the face to droop on one side. Sometimes that's not very obvious to us, but it frequently would be obvious to family or friends or someone who knows the patient. And then the third is one-sided weakness. We don't use grip strength as much as we use the arm drift test, where you have the patient hold their arms in front of them, close their eyes, and then they will be unable to keep their arms, keep the one arm up when they fail this. So patients that fail the Cincinnati Pre-Hospital Stroke Scale have slurred speech or facial droop or one-sided weakness, and those are patients that we are very suspicious of are having an acute stroke. Patients can have what's called a transient ischemic attack, or a TIA. Many patients call these mini strokes, mini as in small strokes. And these are indicative of carotid artery disease. The symptoms look just the same as a stroke. The only difference is that the symptoms resolve in less than 24 hours. And so typically you won't be able to tell pre-hospital whether the patient is having a TIA or a stroke. These patients will look the same to you. So the management and assessment of our stroke patients includes maintaining the airway, supporting breathing, supplemental oxygen as needed, quick and accurate application of the Cincinnati Pre-Hospital Stroke Scale. So we're looking for slurred speech, facial droop, one-sided weakness. We're going to assess and manage that blood glucose because, as you remember, hypoglycemia, low blood sugar, can certainly mimic a stroke. So we want to correct the blood sugar. And then early notification of the receiving hospital, with the goal being the ER time to be as short as possible. So anything that we can do to help speed those patients through the emergency department, including gathering information so they can be registered quickly, an accurate spelling of their name, last 4 of their social security number, date of birth, that sort of thing. Anything that we can do to help speed that patient through the ER to the CAT scan where the type of stroke can be determined, that's what we should be focusing on. We should position our patient with protection to the paralyzed extremity. We probably don't want to do blood pressures in that extremity unless we just have no other choice. There's some evidence that those blood pressures in the affected or in the weak side extremity are not accurate. We want to know when the patient was last known well, and so one of the key things is to bring family or friends with the patient, or at least get a cell phone number or good contact information for them, and urgent, rapid, efficient transport. Medics will use an IV, typically the right side. Medics will monitor the cardiac rhythm, get a 12 lead if possible, and then they'll obtain a detailed history. But the key thing for us in a first response role is to do an accurate pre-hospital stroke scale, and then to begin efficiently moving that patient to the ER. Here are a number of links for further information if you want to look into some of the stroke treatment and know more about stroke. And we'll distribute this as a PowerPoint document where these links will be live. There's quite a few very good sources on here if you want to know more about stroke, and particularly more about stroke treatment. There's some very dramatic treatment that can be done both with clot buster medication as well as the mechanical clot retriever tool. We have a very high level of stroke care in our community, and these links will help you get some more information on that if you're interested.